Welcome to Discussions with Dr. G. Today we are going to get down to brass tacks and introduce you all to antimicrobial therapy. I'm Dr. G, and I'm happy to be your sarcastic guide through the microbial minefield. Today we're talking about choosing the right antimicrobial, which is basically the difference between being a hero and, well, creating the next superbug. No pressure, right? So first up, let's classify these little miracle workers, shall we? We have four main types: antibiotics, antivirals, antifungals, and antiparasitics. Antibiotics are your bacteria bashers. Some kill outright, some just stun the bacteria and let the immune system finish the job. Then you've got antivirals like oseltamivir, otherwise known as Tamiflu, which only work if you catch the virus before your patient's WebMD search gets out of hand. Antifungals, those are for yeast and moldy situations. Basically, if it ends in azole, you're probably in the right ballpark. And lastly, antiparasitics. Well, those are rare, but definitely unforgettable. Trust me, you'll never look at a glass of lake water the same way again. Now, antibiotics themselves are a whole zoo. Penicillins, great for gram-positives, until MRSA shows up and laughs in your face. Cephalosporins come in 5 generations, each one a little more intense than the last. Macrolides like azithromycin are good for atypical infections and for people who enjoy a little GI chaos. Fluoroquinolones, these are broad spectrum, but don't be surprised if your patient complains about their Achilles tendons. Tetracyclines, just say no to sun and dairy. And aminoglycosides like gentamicin, these are for big infections, but don't expect your patient to hear you clearly after a while. Oh, and speaking of mixing things up, let me tell you about my first semester teaching pharmacology. I confused a cephalosporin with a penicillin in front of a room of eager nursing students. You think I'd committed a cardinal sin. It actually sparked this wild debate about cross-reactivity and allergies. Half the class was convinced you could never give a cephalosporin to someone with a penicillin allergy. The other half was ready to roll the dice. Spoiler, it's not always black and white, but we'll get to that. Anyway, I survived, and so did my reputation. Barely. All right. So how is the right antimicrobial actually picked? It's not just about grabbing the fanciest drug on the shelf. There is lab work involved, and they are looking at the causative agent. So, culture before you nuke, unless it's sepsis, then you move fast and draw cultures stat. The site of infection matters too. Not every drug crosses the blood-brain barrier, and some don't even try. Drug sensitivity? That's where your hospital's antibiogram comes in. Yes, it's real, and no, it's not just a fancy chart that gets ignored. Allergies are a big one. If your patient says they're allergic to all antibiotics, please dig a little deeper. Rash doesn't always mean anaphylaxis. And don't forget cost, because, healthcare budgets don't print themselves. Empiric therapy is your best guess while you wait for cultures, and definitive therapy is what you switch to once you know exactly what you're dealing with. Think of empiric as the pregame, definitive as the final boss battle. Now let's talk about the patient themselves. Immune status is huge. If they are immunocompetent, you can sometimes get away with bacteriostatic agents. These stop the bacteria from growing or multiplying, but don't directly kill them. They freeze the bacteria in place so the patient's immune system can finish the job. If they are immunocompromised, don't get cute. Go straight for the bactericidal stuff. These kill bacteria outright. They destroy the cell wall, disrupt proteins, or otherwise wipe the bacteria out directly. Neutropenic patients, You're starting broad spectrums now. Do not wait for the lab to call you back. Age, another biggie. Neonates have immature livers and kidneys, so avoid things like sulfonamides. Elderly, their organs are tired, so adjust the dosage. And always calculate creatinine clearance, not just serum creatinine, especially for frail grandma. Pregnancy and lactation. Some drugs cross the placenta and milk production. Avoid tetracyclines, aminoglycosides, and fluoroquinolones if you can. Always check the FDA pregnancy category, even if the OB says just give it. This is where being a registered nurse is important and questioning orders, okay? Renal and hepatic function matter too. Many antibiotics are excreted renally, so if the kidneys are struggling, you need to adjust. Same goes for the liver. If it's cirrhotic, watch out. And allergies, a patient with a penicillin allergy doesn't always mean cephalosporins are off the table, but if they have a history of anaphylaxis with penicillin, cephalosporins are a hard no. Don't forget the site of infection. Not all antibiotics get everywhere. CNS infections, you're going to need something that crosses that blood-brain barrier. UTIs, go for drugs that are renally excreted. Abscesses, sometimes you need to drain before you medicate. Antibiotics don't work well on pus pockets. Let me give you a real-world example. I was hospitalized with sepsis. The nurse was administering strong, broad-spectrum antibiotics as ordered. When my labs came back, she checked the hospital's antibiogram, and my initial culture showed resistance to our first choice, so she had to pivot. She had to balance the culture results, my allergies, and the site of infection. It's not about memorizing drugs, guys. It's about thinking critically and maybe sweating a little. All right. So you've been ordered a drug. You've double-checked the allergies, and you're feeling good. But you're not done yet. Monitoring is where you keep your patient safe and keep your license intact. Let's talk peak and trough, especially for drugs like aminoglycosides, vancomycin. Peak level is the highest concentration of the drug in the bloodstream after it's been given. Think of it as the drug's performance high. Trough is the lowest concentration. It's measured just before the next dose. It's the quiet valley, if you will. You want the drug to be effective, but not toxic. Think Goldilocks medicine. Not too high, not too low, just right. So why do we measure these? 2 reasons: efficacy and safety. You want to make sure the drug is actually killing microbes, but you also want to avoid things like nephrotoxicity and ototoxicity, especially with aminoglycosides and vancomycin. These drugs have a very narrow therapeutic window, so timing is everything. So when do you draw these levels? Trough is usually drawn within 30 minutes before the next dose. Peak depends on the drug and how it's given. IV drugs usually 30 minutes to an hour after the infusion ends, but always check your facility's guidelines because policies can vary. Timing matters and documentation is precise. So let's wrap this up. Antimicrobials save lives, but only when you use them wisely. Know your drugs, know your patient, and don't forget to monitor. And if you ever find yourself second guessing, just remember it's better to ask than to accidentally train the next generation of resistant superbugs. All right, that's it for today. Next time we'll dig even deeper into the world of antimicrobial therapy. Until then, keep your sarcasm sharp and your vancomycin troughs on time.